Hello, and welcome to this medical emergency podcast on anaphylaxis. During this podcast, I'm going to talk about the definitions of anaphylaxis, important causes to be aware of, the clinical features, and finally, the treatment principles. So let's start with some basic definitions. Generally, anaphylaxis can be defined as an acute, generalized, and life-threatening allergic reaction. The usual pathogenesis is a type 1 IgE-mediated response with release of histamine and other vasoactive mediators. This is known as an anaphylactic reaction. Remember, however, that anaphylactoid reactions also present in this fashion. In these reactions, the same mediators are released, but the reaction is not antibody-mediated. Certain drugs, such as morphine and contrast dyes, are particularly associated with these anaphylactoid reactions. The most important causes of anaphylaxis are, as we have said, drugs, and relevant examples might include penicillin, aspirin, and contrast media. Latex is another important cause of anaphylaxis, as are stings and other venoms. Particular foods are also important to be aware of and include eggs, fish, peanuts, and strawberries. Remember that it is possible to be allergic to anything. The clinical features of anaphylaxis can be figured out from knowing that the mediators released in the reaction cause capillary leakage, mucosal edema, and smooth muscle contraction in pretty much all the organ systems in the body. Let's go through a few of the most important systems that are relevant to the clinical presentation. Changes in the skin are very important, as nearly everybody with anaphylaxis will have a degree of manifestation here. The most important signs and symptoms are pruritus and erythema. There may also be urticaria, this is shown in the picture on the slide, and is characterized by red, raised, itchy lumps that are often called wheals. Angioedema, also known as Quincke's edema, is swelling of the dermis and subcutaneous tissues. This is similar to urticaria but occurs much deeper. It may be seen anywhere on the body, but usually affects the lips and tongue. In fact, swelling of the tongue in angioedema can be so severe as to block the airway. So for the respiratory system, we have bronchospasm and associated wheeze that can be heard with your stethoscope. There can also be laryngeal edema and associated stridor. Cyanosis may of course result from both of the above. For the cardiovascular system, there may be hypotension, tachycardia, and the development of arrhythmias, either supraventricular arrhythmias such as AF or ventricular arrhythmias such as VT. In the abdomen, there may be pain due to smooth muscle contraction, nausea and vomiting, as well as diarrhea. So let's talk now about basic management of the patient in anaphylaxis. The first principle can of course be applied to any medical emergency. Call for help and make sure the patient is in a safe place and attached to monitoring equipment. Next, we move on to A, B, C. That's airway, breathing, and circulation. With respect to the airway, it is important to secure, as remember there may be considerable laryngeal or tongue edema as part of this reaction. It's worth getting anaesthetic involvement as soon as possible, as intubation may be needed. In terms of breathing, you should of course monitor the saturations, respiratory rate, and effort, and also listen to the lungs for air entry, wheeze, and stridor. But from a therapeutic point of view, it is important to give high-flow oxygen. This will usually be 15 litres per minute through a non-rebreather bag. If wheeze is a predominant sign, then you should also consider giving salbutamol nebulizers. These work by antagonizing beta-2 receptors, helping to open up the constricted airways. In terms of the circulation, it is important to monitor the pulse, ECG, and blood pressure, and of course to gain intravenous access with 2 large wide-bore cannulas. You also want to give various drugs. The most important drug to be aware of is adrenaline, 0.5 milligrams IM. The IM or intramuscular bit here is very important. Under no circumstances should you give this intravenously. If the patient's reaction is getting worse, it is possible to give adrenaline every 5 minutes. The next drug to think about is the antihistamine chlorpheniramine, usually given at a dose of 10 milligrams intravenously. This helps limit ongoing inflammation. Finally, consider giving some intravenous hydrocortisone. 100 milligrams IV is a common dose. Remember that hydrocortisone has little effect immediately, but helps to prevent subsequent late-phase allergic reactions. If the blood pressure is difficult to control, you can also fill the patient by giving intravenous fluids, typically 0.9% saline. An example of a regime here would be to give 500 ml, say over 15 minutes. However, generally, the fluid should be titrated against the blood pressure, and in young healthy people, up to 2 litres of fluids may be given in a very short space of time. Important further management principles include omitting the patient and supporting their vital functions. This should be done for a minimum of 12 hours, as often symptoms of anaphylaxis may recur some hours later due to the biphasic nature of an anaphylactic reaction. Remember that the hydrocortisone that you give helps to prevent this relapse. It is also important to refer all patients who have had an episode of anaphylaxis to a clinical immunologist for investigation of the trigger factor and education about their condition. Also, patients should be given self-injectable adrenaline and should wear Medi-Alert bracelets or carry allergy cards with them. So, in summary, anaphylaxis is an acute, life-threatening allergic reaction that can be caused by a number of things. Clinical features can basically be figured out from these principles, with the most important clinical manifestations occurring in the lungs, heart and vessels, abdomen, and the skin. Important drugs to give in anaphylaxis are adrenaline, remember I am adrenaline, chlorpheniramine, and hydrocortisone. It is also important that all patients are admitted for a minimum of 12 hours and see a clinical immunologist. So that completes this podcast on anaphylaxis.